Hi everyone, this is Allison, and I'm going to be telling you a little bit about Entamoeba histolytica. Entamoeba histolytica is a pathogenic amoeba that can cause intestinal as well as extra-intestinal infections. The disease is spread primarily via the fecal-oral route. It may also be spread if an individual is exposed to fecal matter during sexual contact. The infection is typically spread via contaminated water or food, often due to improper handling and lack of hand washing. Mature cysts of the disease are ingested and move to the small intestines. Once there, those cysts rupture and release trophozoites, which multiply and then go on to produce new cysts. Those new cysts are then passed through formed stool and can live outside of the human body for days to weeks due to the protection that they receive from their walls. Trophozoites, on the other hand, are typically only passed through liquid stool and can't live for long outside of the host. If they did happen to survive long enough to be ingested after being passed through the stool, they would likely be killed by the acidity of the gastric environment because they don't have that wall to protect them. Trophozoites can, however, live in the intestines of an asymptomatic individual, making them an unknown carrier of the disease who is likely passing these mature cysts on to others. Entamoeba histolytica is most common in areas with poor sanitation. It is often also seen in immigrants or those who have recently traveled to countries where there's poor sanitary conditions. Those living in institutions such as prisons with poor sanitation are also at an increased risk, and homosexual men are more frequently infected. An official diagnosis of the disease can often be difficult to obtain because Entamoeba histolytica can look very similar to other parasites when observed under a microscope. Entamoeba dispar is another parasite that's actually about 10 times more common and looks very similar under the microscope. This parasite does not make individuals sick though, so people may be treated unnecessarily if misdiagnosed. So moving on to signs and symptoms, there are a wide variety of presentations available. As I had mentioned earlier, an individual infected with Entamoeba histolytica may actually be completely asymptomatic. They may just be a carrier. An individual may also develop intestinal disease due to invasion of the intestinal mucosa by those trophozoites. Common signs and symptoms are typically loose stools or diarrhea, stomach pain, and or abdominal cramping. These symptoms typically develop within 2 to 4 weeks from the time that an individual was exposed. However, it can take longer, and the onset of symptoms is typically gradual. Rarely, the disease can become a little bit more severe, which can lead to amoebic dysentery. When this occurs, symptoms include some worse stomach pain, bloody stools, and fever. Occasionally, individuals may also develop extra-intestinal disease. This occurs when the Entamoeba histolytica travels from the intestines into the bloodstream. From there, the infection may travel to the individual's liver, where it forms an abscess. The Entamoeba histolytica may also travel to the brain or lungs, which is very rare. And in general, any sort of extra-intestinal disease is fairly uncommon. Treatment recommendations for Entamoeba histolytica depend on the clinical presentation of the individual. Asymptomatic carriers should be treated to prevent the disease from being spread to other individuals. We wouldn't necessarily run into this in Africa because anyone we're going to see is probably symptomatic, which is why they're telling us about it. But in other situations where providers do have access to obtain stool samples and things, they may find an asymptomatic carrier. But between 4 to 10% of individuals who are initially asymptomatic will ultimately develop intestinal disease, making early treatment the best option. In this case, individuals are treated with either paramomycin or iodoquinol. So the dosing for the paramomycin is the same for both adult and pediatric patients. They would be given a range of 25 to 35 milligrams per kilogram per day, divided out into 3 doses. The length of treatment for that would be 7 days. As far as pregnancy category, that was not identified. The iodoquinol, on the other hand, adult dosing would be 650 milligrams 3 times per day for a total of 20 days. Again, pregnancy category was not identified. The pediatric dosing for that would be 30 to 40 milligrams per kilogram per day, with a maximum dose of 2 grams per day, divided out in 3 doses. And again, that would be a 20-day treatment course. So just for knowledge sake, those asymptomatic carriers would only be treated with the paramomycin or iodoquinol. Individuals we would see would likely have intestinal or symptomatic disease. For this, the recommendations state the individual is first to be treated with metronidazole or tinidazole. So for the metronidazole, adult dosing would be 500 to 750 milligrams 3 times per day, with the length of treatment between 7 to 10 days. This is a Class B pregnancy drug. For pediatric dosing, it would be 35 to 50 milligrams per kilogram per day, divided in 3 doses, again for 7 to 10 days. With the tinidazole, the adult dosing would be 2 grams 1 time per day, and the length of treatment actually depends on the severity of their disease. So it would be a 3-day course for mild to moderate symptoms, or a 5-day course if the individual was having severe symptoms. And the tinidazole is a Class C pregnancy drug. For pediatric dosing, it would be 50 milligrams per kilogram per day in children less than or equal to 3 years old. And again, with the dosing length of treatment, it would again be 3 days for mild to moderate illness, or 5 days for severe symptoms. So once the first medication, either the metronidazole or tinidazole, is completed, individuals should immediately complete a course of either the paramomycin or iodoquinol at the same dosing previously described for the asymptomatic individuals. So those with symptoms actually get treated with 2 drugs back to back. So with the pregnancy categories, with Class B drugs, according to the FDA, animal reproduction studies have failed to demonstrate a risk to the fetus, and there are no well-controlled studies in pregnant women. With the Class C drugs, the animal studies have shown an adverse effect in the fetus. There's no adequate studies in humans, but potential benefits may warrant the use. So based on this assessment, the metronidazole would be the preferred drug to use in pregnant women over the tinidazole. Neither paramomycin or iodoquinol have an assigned pregnancy class, and according to Dynamed, fetal and or infant risk if a mother is breastfeeding can't be ruled out when using these drugs. So as far as preventing the disease when we're there, or for teaching points, good hand washing is essential, especially with the knowledge that so many people can be asymptomatic carriers, and those cysts can live so long outside of the human body. So when traveling to areas with poor sanitary conditions, it's important to be conscious of the things you eat and drink. Avoid fruits or vegetables that you cannot peel or that you did not peel yourself. Also watching out for unpasteurized milk, cheese, or dairy products, avoiding those, and then drinking only bottled water or tap water that has been boiled. So that about sums it up. Thank you for listening about Entamoeba histolytica.